Angeline, mom of 3 and founder of SavvyMamaSG. Welcome to A Mama's Diary, a space where we talk honestly about motherhood, the struggles, the surprises, and everything in between. Today, we are diving into a topic that every mama thinks about: pregnancy and childbirth. From those scary moments in the first trimester to the myths, worries, and fears surrounding delivery, we'll be covering it all. To help us cut through the noise and get to the facts, I've invited Professor Christopher Chong, Senior Consultant Obstetrician, Gynaecologist, and Urogynaecologist. He's a trusted Gynae who's delivered over many countless babies and also a pioneer in pelvic floor and incontinence care. With over 30 years of experience, Dr. Chong is here to help us bust common misconceptions and give you more confidence as you prepare for motherhood. So let's get started. Many moms in the first trimester experience cramps and immediately worry about miscarriage. How do we know what is normal and when to be concerned?
Usually, the risk of the patient in the first 3 months is that of miscarriage, and the last 3 months, that of premature labor. So for miscarriage, usually people look out for any bleeding. Any bleeding in pregnancy is abnormal until proven otherwise. Occasionally, they can have cramps, but if cramps comes and disappear, then it's not worrying. But any cramps that continue and progress to more and more cramps and does not go away, then we need to see the doctor and find out whether there's a reason. Common reason would be infection, because in pregnancy, the person's resistance drops. So it's easier to get infection both from the vagina and the bladder. So if it's an infection that is treated, then most of the time the symptoms will subside. So the other thing that is very challenging in the first 3 months often is nausea and vomiting. Some people vomit until they cannot eat at all, they get dehydrated. If you don't eat food, your bodies have stores for 3-4 weeks, not a problem. But if you don't have enough fluid, you get dehydrated, it can affect your baby. So these are the few common symptoms: nausea, vomiting, bleeding, cramps, and anything unsure, simple thing, see your gynecologist.
Okay, thanks for that. Because I had bleeding during my first pregnancy, once at week 5 and again at week 8. I remember being at work, I was like crying as I drove myself to the hospital. Then they did a probe test for me, but then I was just told to go home. And then while waiting, I was told to go back in 2 weeks' time. So I was crying every day, and like I Google online, it's like I tick off all the symptoms like bright red bleeding, like nobody said that it's actually okay. Yeah.
Actually, generally, it's very stressful and very scary for the patient to have bleeding, because everybody wants the pregnancy to go on well. And I think you need a lot of reassurance from your gynae, because otherwise at home you'll be like Angeline, Google, worry, crying, husband also couldn't do anything. So that's not ideal. You need enough support. Mental support is very important in a pregnancy, because it's a tough thing that every woman go through. Unfortunately, about 20% of women bleed in pregnancy. Majority of the times, nothing is wrong. Especially when you do an ultrasound scan and can see the fetal heart. That's very reassuring. Of course, even if you see the fetal heart, the bleeding cannot progress to worse and worse and longer. It must stop somewhere. So doctor's duty is always try to find a cause for the bleeding. Very often, the cause cannot be found. Common causes include hormonal imbalance. So sometimes when you bleed, the doctor may give you a hormone jab as a womb support. Infection can be a cause of bleeding, which is very common. And then intercourse sometimes, because in pregnancy, the cervix open up a little bit to be on the raw side. So if during intercourse, the penis touches the cervix, it can cause some staining. So those are the common signs. Very importantly, when a person is bleeding, we don't want them to move too much and exert. When a person bleeds, how does the bleeding stop? It's because a clot will form. If the clot does not form properly, your bleeding will not stop. So if you are resting for a while, you're well, you're not bleeding, and suddenly you do your housework and go running, the clot will break and you start bleeding again. So sometimes rest is very important when one is bleeding. But the important thing is to find out whether there's a cause. If you can find the cause, treat the cause. Otherwise, If you can't find a cause, we have no choice but to give you hormone support, either injections, oral, and to have some bed rest until everything settles down.
Yeah, I think that was a very painful process that we went through, because I did realize, like, when I stand up, more blood would come out. So I just sit down the whole time.
And the other thing, of course, is more reassuring. If you're bleeding, you're worried, see the doctor more often, because from the time you're pregnant until about 20 weeks, especially for first child, you do not know how the baby will be. Baby movements for first-time mother starts from 20 to 22 weeks. After 20 to 22 weeks, if the baby moves, you know, my baby is all right. But before that, you require a scan, an ultrasound scan. Fortunately, this is not X-ray. You can do as many as you want. And to see the heartbeat and baby being well is very reassuring for the mom and the doctor.
Food is another huge source of anxiety. Can pregnant moms drink coffee? What about sashimi, half-boiled eggs, or other raw foods?
In general, I tell my patients in pregnancy, no drinking, no smoking, and no herbal products.
Oh, no.
Because in some communities, sometimes they give you this herb, that herb, and then anything you do not know, please do not take. But generally, as long as you don't smoke, don't drink, usually you're fine. Raw food is no, so it's not safe. Coffee is because of caffeine. In a pregnancy, you're allowed up to 200 milligrams of caffeine a day. 1 cup of coffee is about 80 to 100 milligrams, so 1 cup a day should be fine. So generally, I will tell them no raw food, and most of the time, whatever you eat normally is okay. If people tell you, oh, don't take pineapple, there's a risk of miscarriage. But there's no proof and no studies on it. So if you don't have to take it, don't take it. It will not hurt you. But you, by some chance, you go to a Thai restaurant and eat pineapple rice and eat some pineapple, don't panic. So in general, just stay healthy. Take the normal food. Don't take anything that you're unsure of. And make sure it's cooked food.
How about those pasteurized half-boiled egg?
There are pros and cons, and people who are unsure, but usually generally boiled eggs is safer. And some people say certain cheeses cannot be taken, like swordfish, for high mercury content shouldn't be taken. I mean, I don't think people take that all the time, so should be all right. Try not to take them.
Okay.
Yeah.
So many moms tell me their biggest fear is ending up in an emergency C-section. Is that really as common as we think? Because to be honest, that was also one of my biggest fears too, especially with my second child, because she took such a long time to come out. And then she turned out to be a huge baby, around 4 kg.
My goodness. I hope you are doing your pelvic floor exercises.
So right after that, I had incontinence for many months. Yeah.
Well, just on that alone, if a person has stress urinary incontinence during pregnancy, if at 3 months she still has stress urinary incontinence, 95% of this group of people 5 years later will still be leaking urine. So you must be very careful and do your pelvic floor exercise to prevent stress urinary incontinence. So coming back to your question, C-section or normal delivery, that's everybody's question, right?
Emergency C-section.
Yeah. So emergency C-section can always occur. Even though a person has delivered 5 kids normally, by normal vaginal delivery, the 6th, you can still end up in a C-section because many things can occur in labor. Labor is dynamic, it's not static, so things can change. Such as, for example, if there's sudden bleeding, if the baby's heartbeat drops, or in some patients, maybe the blood pressure of the woman climbs very high, or the patient climbs very high, then we have to do an emergency C-section to save the baby. Generally, we always say C-section is safer for the baby. Normal delivery is safer for the mummy. Why? Because normal delivery is not an operation. C-section is. And if for the baby, if they go through normal delivery, sometimes they have the stress of labor, including contractions. So sometimes heartbeat drop, or for example, like your second baby, if the labor is prolonged, then it can put a lot of stress both on your womb, on you and your baby. So emergency section will occur if the 3 P's cannot be fulfilled: power, passage, passenger. So for normal delivery, you have to fulfill these three, right? Power is contraction. I can control with medication, not an issue. Passage is your bone. Bone controlled by God. It will not change. Passenger is the baby. How big, how small, whether the head of the baby looks up this way, this way, this way, this way. They have different diameters. So if it's a face presenting, there's no way the baby can come out. So it's all diameter issue. So if the baby were to come through, then there must be enough space through the bone.
But how you can't tell, right? It's like during the labor.
Unfortunately, we cannot predict who will end up in a C-section. You have to go into labor to see progress of labor. Progress of labor is when slowly your cervix open up to 10 centimeters. At 10 centimeters, the doctor will tell you you can start pushing. Before that, please don't push. Otherwise, if you push too early, your cervix becomes very long. Next time, it can stick out of your vagina, and you need surgery to solve that. So when at 10 cm, you are asked to push. When you push, there must be descent. That means the head must start coming down through the pelvic area. If it's always stuck inside, it cannot come down. Sometimes it's because the bones are too narrow. Then, in that case, bones. That's right. And the pelvic bone can be angled like that, like that, like that. Depends on how the angle is as well. And of course, how the neck of the baby is flexed and which direction the head is. So all this will affect whether a person can go into normal delivery or not.
How long should we wait before deciding on emergency C-section? Because most people will still try for natural, and then how long do you...
There's no fixed time of how long you can wait. We always look at progress of labor. The first 3 centimeters of the cervix opening, when the cervix is not thin out like paper thin, it can be long. It's called the latent phase of labor. Once it becomes very thin, at least it will open at least 1 cm per hour, provided contractions are good. So when it becomes paper thin, let's say you're at 3 cm, so within 7 hours, we expect you to be fully open, if not earlier. So that's a rough kind of time frame. But there's no fixed time. As by 5 hours, by the C-section, by 10, 15 hours, no fixed time. There must be good progress. Progress of labor include cervix opening fully, head coming down nicely. All these are important things.
So
and everybody must be mentally prepared that they may end up in a C-section because everything is unpredictable, even though you have delivered many vaginally before, because things can happen. So if your patient is very fixed on the idea that I will deliver normally, and she ends up in a C-section, sometimes they get into depression. They think that the failure, which is absolutely wrong, is no failure to have a C-section. So you must be mentally prepared for what will come next and prepared for anything. So it doesn't mean that you have a normal delivery all the time, even though you had them before.
Okay, so in general, is it right to say that natural birth is safer than C-section, or
yes and no?
Yes and no.
Yeah. So every individual is different. I had a patient, a small size girl, smaller than Angeline, and she wanted to have to a normal delivery, very, very much. So eventually she delivered. Baby was quite big. Eventually it had to be vacuumed out. She tore through her anal canal. So during the time, and she had a long labor. So after delivery, I stitched her up. But because her tissues were so swollen, the stitches broke down the next day. So once you have a tear through to the anal canal, your feces can come out from the vagina. So after that, I told her I will get somebody expert in this to, even though I was the expert. So sometimes we need another opinion. We got a colorectal surgeon to do the stitching 3 days later. So he stitched up that area. 2 days later, it broke down. Then after that, she went back home, and 1 month later, she looked for another colorectal surgeon. And at 1 month, she underwent general anesthesia in the operating theatre, had the area repaired. Within a week, it broke down.
Oh my God.
3 times. So this time, 3 months later, she went back to the same colorectal surgeon. This time, he put a netting called a mesh in the area of surgery. She succeeded. She was well. She became continent, not fecal incontinence or leaking feces from the vagina. So 2 years later, she came back to see me and pregnant again. So when she walked in, I told her, if you want a normal delivery, please see another doctor. So she said, no. This time I want a C-section. So it's not always that everyone can achieve, and not always that normal delivery has got no complication and not traumatic. Having said all this, C-section may not be that bad, because C-section protects the pelvic floor up to 3 C-sections. That means the 4th one, you're like a normal person with normal delivery, no further protection. Protection of the pelvic floor means that your risk of urinary incontinence and womb prolapse or lax vagina is much less. So there's some good in it, other than not traumatizing the baby by going through the canal. So in Singapore, the C-section rate is almost reaching 40%, so majority can still do a normal delivery. But yet, we have to be very sure that it is possible, because if it's not possible and you force a baby through a narrow canal, sometimes you can hurt the baby, damage the skull, for example. Now, for a person who have gone through a C-section, if the reason for the C-section is not there, that for the second delivery, for second pregnancy, they can try for normal delivery. We call it VBAC, vaginal birth after C-section. Why do people want to do such a thing? It's because in general, if you can succeed in vaginal delivery, your recovery is faster than in a C-section, which is an operation. My sister-in-law, I deliver families, including my own kids. My sister-in-law had twins.
Wow.
She's an anesthetist, husband anesthetist. So I delivered her by C-section. But the next baby, it was single. So the previous reason for C-section wasn't there. And because the previous C-section I did for her, there was no complication, everything smooth, we went through a VBAC for her and she succeeded.
Is there any benefits for the baby? Like I mean, I've heard that if the baby goes through the birth canal, there are like some nutrients or things that benefits that you for the baby when you go through the
There
birth
are
canal.
some studies to say that if you go through the canal, you pick up some of the bacteria. It may be good for your immune system. But generally, we have to be quite careful about that. Because of that belief, there was once a study that used the study group of people used a swab to swab the vagina for the bacteria and put in the mouth of the baby so that they can get the bacteria. And this was a group of people who had C-section to take the discharge and put in the mouth. I think that is very, very dangerous, very unsafe, because the baby is young and vulnerable. Why do you want to put bacteria into the baby? So sometimes we have to be quite careful. The fact that 30% of deliveries in Singapore are done by C-section, yet most of the babies are healthy. So in certain places, maybe certain parts of China, it can be up to 70 to 90% of C-section. And generally the babies are also healthy. So there may be some use, but I don't think it's crucial. So it's whether you can do it or you cannot do it.
Right.
I had another patient. She had a C-section first time round because she went into labor, and then the labor was long, baby couldn't come out. She delivered a 3.6 kilogram baby. Second baby, she wanted to try for normal again. I said, yes, it's okay because your C-section was not complicated. If the C-section was complicated by bleeding, infection, or there are many tears in the womb during the C-section, we will ask for a repeat C-section. But every smooth C-section you can try for a normal delivery if it's one C-section. If you had 2 C-sections, the third one must be a C-section. So eventually this patient succeeded. After that, she came and told me this. Doctor, I want to tell you a secret. I said, what? I said, I dieted. So I said, you silly girl. Luckily, nothing happened. She dieted and she gave birth to a baby 2.8 kilogram.
Because it's easier to...
So 3.6 couldn't come out, 2.8, no problem. So sometimes it's also size of the baby.
I really think size matters actually, because my first and my third, so first one 3.4, third one 3.4. So first one, fourth push, she was out, and the third push is out already. But second one was like
Second one was too big.
45 minutes, I still couldn't see her come out, so I was crying already. I was like, maybe I'm going to do emergency C-sec because it was so difficult.
Luckily, you succeeded. The other thing is, of course, the position of the head. Most baby, when they're born, the face will face the ground. Let's say if the face is the other way around, facing the ceiling at birth, up to 50% of them end up in C-section because the diameter becomes too big and you push for a long time. Sometimes push so long that you're so tired. Yeah.
I recall that they actually turned the baby to come out.
Maybe they did because of the positioning as in up and down. So sometimes like your vacuum to pull the baby out, it can cause the turning. In the old days, there are different types of forceps to especially turn. But because of the lack of use of these forceps and training, they have lost the skill. People like us, we can still do it, but the young ones have lost the skill to turn the baby using forceps, and it becomes dangerous to do that. So, but these days, because of the vacuum cup, it can turn by itself, so it's safer in that sense.
Does age really matter for whether you should do a C-section or natural?
Age itself is a factor because the older you are, the more risk you have for most things, include miscarriage, high blood pressure, diabetes, premature, and above the age of 40, sometimes if you're having your first child, we consider whether to discuss a C-section with you because you're not going to have so many more. People who had many miscarriages can have a discussion whether they should have C-section. People who went through an IVF, in vitro fertilization program to get a baby after trying many times can have a discussion of the option of C-section. Why do we do that? Because it's deemed safer for the baby, and of course every baby is very precious, but even more precious for such patients. So the older you are, the less healthy or less strong you will be. So age is a factor. Can you imagine delivering at 50 years old compared to a 25 years of age patient? Certainly is different. So in general, in the old days, 35 years old is considered elderly. But that was during an era when the life expectancy was 60 to 65. But today our life expectancy has gone up to 85. So we have pushed the boundary to about 40. But still, it is better to deliver earlier than later for a few reasons. The quality of the egg will start going downhill from the age of, what age? Would you guess? 25.
25?
Okay.
Oh no.
So from 25 it goes down a little bit. At 35 a lot, 40 even more. So we generally hope that all our patients can deliver before the age of 35. But unfortunately in today's Singapore society, people marry late, they start late, they have stress of work. So sometimes it's not easy to get a baby. And you are not sure of your fertility until you try to have a baby. So do consider all these things, prepare for pregnancy. There are certain things you should do and should not do, and then plan early.
Does the quality of the man's sperm also affect? Or?
Of course, because the baby is an egg and a sperm thing, but the quality of the sperm will not go downhill so quickly as compared with the egg. So, for example, a man can be 50 years old,
Okay.
the sperm is still okay. But when a lady is at 50, the egg is not okay.
Right. So there will be other problems with the fetus and...
Correct. So, just very simple numbers. At the age of 35, the risk of Down syndrome in a lady is 1 in 330. Age of 40, 1 in 100. Age of 45, 1 in 50. So you see how badly it goes down.
Yeah, when they tell us all these stats, I always like, don't tell me, just tell me that my baby is okay.
No, but the good thing these days, fantastically, we can take the blood from the mummy and test for the genes and chromosomes of the baby. It will not hurt the mummy or the baby. So it's a very simple test with accuracy of up to 99%, and can tell you the gender of the baby as well.
We did that for second, third. So as a new mom, all things equal, what should we aim for?
Well, you must first know yourself. Some people are worried about going through long labor. And of course, there are certain indications for C-section. You have no choice. For example, if you have a low-lying placenta, the placenta blocks the opening of the cervix for the baby to come out. You have no choice. Very often we do C-section for multiple pregnancy, or we do C-section when the baby is not growing well, already is compromised on the health, and you stress the baby through labor, then the heartbeat may drop, then you have to run to do an emergency C-section. So, and usually we do that for multiple pregnancies as well. And for people who had previously had surgery done on the womb, for example, you have a huge fibroid growth in the womb and you had, say, 10 cm and you cut in the womb and stitch in the womb, we worry that the part of the area where you stitch is not strong enough during labor, because labor you contract, it may rupture. If you rupture, mother can die, baby can die. So, or when you have previously had, say, road traffic accidents before and your pelvic bones are all damaged, then you shouldn't go through a normal delivery. So those are absolute indication. So there are some people who want C-section because they want to select time, horoscopic C-section, 3 a.m. on a certain day. So then they have to do. But in general, we allow every first-time mom to try for normal delivery, because until you go through labor, you will not know whether you will succeed or not. But having said that, even though we allow all the first-time moms to try for normal delivery, not everyone will succeed. So they must be mentally prepared that there is still a chance to fail. Of course, your own gynecologist will do assessment for you. And at full term, usually we do an internal examination called vaginal examination, where we assess the narrowness of the pelvic bone. At the same time, we also scan to make sure the baby is not too big. Then we can give you an idea of your risk of having a C-section. Then you can make an informed decision. If a person has got diabetes, for example, that's why we screen for diabetes at 24 to 28 weeks for all our patients. If it's not well controlled, then there will be a lot of deposition of fat and tissues around the shoulders. Normally, the biggest part of the baby is the head. So if the head can come out, every part can come out. But for diabetic patients, especially not well controlled, the head can come out, but the shoulders become so big, so sometimes the shoulders get stuck, baby can die under your eyes. So all these things are things we look out for. Of course, the very important thing about normal delivery is the head of the baby must be at where the pelvis is. If the head is anywhere else, here, not in the pelvic area, then it means you have to do a C-section. For example, breech baby, backside first. Because as I said, the biggest part of the baby to come out is the head. So if the backside comes out, the head cannot come out because it's so big and get stuck, then baby can die. So these things are quite followed these days as an absolute indication.
And there's nothing a mom can do about it, right? It's just have to...
Position of the baby sometimes can be changed by certain specific exercise called the Elkin's maneuver. The gynecologist can teach you. Low-lying placenta, you can't do anything. It will not change. If it's low, it's low. If you have multiple babies, that cannot change either. And you have previous surgery, of course, then that is not possible to change. But certain things like what I mentioned earlier, if you have multiple pregnancy before, now it's single baby, then these things have changed. The old reason wasn't there, you can try for normal delivery.
Another big area of concern for moms is pain, induction, and use of interventions during labor. Is there some truth to the idea that inducing labor is more painful than natural labor?
One big question to ask you, did you have epidural?
Because they injected the medicine first, so I had to wait for 5-6 hours for it to dilate enough for me to get an epidural. But I did opt for epidural for all three.
Well, in general, pregnancy need not be painful. So that's the myth actually, that people think pregnancy is painful. And for it not to painful, we talk about pain relief. There are basically 3 types of pain relief. One is called the laughing gas, called Entonox. This has to be breathed in at least 20 to 30 seconds before your contraction comes, before it works. But sometimes you breathe so hard, you hyperventilate, so much so that you become very high. And then after that, you start telling the doctors and your nurses your secrets. So, in fact, I had one patient, the husband was so excited that he took the Entonox to breathe also because he was also feeling very stressed. So Entonox is one. Two, injection called Petidin, intramuscular injection. This injection should not be given preferably within 4 hours of delivery because this injection can cross over to the baby and cause the baby to be dopey when baby comes out. Sometimes the baby need some antidote to inject before they can not be so dopey. When baby comes out from the mummy's canal or birth, we want the baby to cry. Why? Because the lungs of the babies in the womb, in the fetus, are collapsed. They are not useful for gas exchange. Gas exchange, food exchange is through the umbilical cord. So if someone tell you, oh, there's a cord round neck in the baby, don't panic because the lungs are of no use and you won't strangulate the baby. But when the baby comes out of the mom, they must cry so that air goes into the lungs so that it expands, and that's when the lungs start working. So don't worry about strangulation. So when the baby is given the injection intramuscularly, they can become dopey, they don't cry well, lungs may not open so well, and oxygen supply may be affected. So the third type of pain relief, which is the most popular these days, is called epidural.
Yeah, it's really magic.
Why epidural? Actually, it's epidural. It's because if it works well, then you feel absolutely no pain. You can use the same epidural for your C-section and will not feel pain, but it must be given early enough. For example, like Angeline's case, if the pain is so bad and is given late, she suffers. When she's in pain, it's difficult for the anesthetist to put in the epidural. And if the head is descended to press onto the rectum, it's too late in her labor, then epidural may not work well. If it's given early and works well, it is called epidural, you have zero pain.
How early is early enough? Because I think initially I didn't have contractions. Not much, at least it was like still manageable. But then in the time when I was given the go ahead to, okay, you can have the epidural, till the time the anesthetist really come, I was like in a lot of pain. I was like begging for it to come each time I was in labor. So I don't know, how early is it? Like, is there an indication?
There is no fixed time, and the pain to different individual can be different. Some people is nothing, some people is like hell. So, but you should know yourself. If you are those type who will be afraid of pain, once you feel the pain coming, you should be asking for epidural, and not until when the pain progresses. So every individual is different. My wife is a dinosaur.
Yeah, she didn't.
She has no epidural, no gas, no injection.
Don't know how she did it.
Right? So I do not know how she did it either. So when I was courting her, I took her blood in the ward to check for hepatitis as part of the employment requirement. She's no problem with pain. But once I showed her the blood, I said, and she said, Chris, you won't believe this, I'm going to faint, and she fainted. So after that episode, I thought she was going to be a lousy patient. And her being a lawyer, sometimes we worry that she'll question. So I pleaded with her to use epidural. But she said, no, I want to try. So eventually I told her, sure, but I work here, please don't embarrass me. That was a joke, huh? But I did tell her that, but jokingly. And she passed with flying colours.
She didn't scream?
No. Then eventually I asked her, how did you do it?
She never
said,
screamed at all. Like,
no.
I was in a lot of pain. I was like,
no screaming. Only thing that she told herself is, I won't push, because I told her not to push before the cervix is open fully. That's the only thing she shouted to herself. I won't push, I won't push. But no other screaming. And she passed with flying colours. She was my best patient. And when I asked her, how did you do it? She said, that's because I expected more pain. It didn't come. So it's all in the mind. So I deliver families, right? So her younger sister also wanted to be like big sister, my wife, without any anesthesia. Within 1 hour, she screamed for epidural. And after delivery, she said, if I had not had epidural,
cannot
I
do
would
it.
have died.
Yeah, that's how
All
I
right.
felt also.
Then her fourth sister, who was an anesthetist, also delivered by me, said this: I don't understand why people want to suffer pain when you have something to help you. So even the same family, different people think differently. So there's no right and no or wrong. So you must know yourself.
Yeah, so so in general you would recommend, but I think it also comes with risk, right? Like I know the needle is very big and thick, and I don't know what they do to the spine and everything, but I was just begging for the pain to end. So I don't know, how safe is it, and what are the possible side effects?
Actually, you are wrong.
No.
The needle is not very big. It's very,
not very big.
thin, very
It's very
tiny. A small little thing going into the spine, but it must be done by expert. Right? So, of course, you can hear of complication of paralysis and wrongdoing. It hardly ever happens. So, in general, the anesthetists themselves will do it. If the anesthetists themselves do not do it, then you wonder why. So, I think it's a very safe procedure. In fact, most of our cesarean section these days are done under spinal or epidural anesthesia because the recovery, the pain relief is much better.
Right.
So there's no right or wrong. Complications of epidural can also include what people are afraid of: back pain, which is common, but usually this resolves by itself within 1 or 2 weeks. And sometimes, if the spinal needle is not placed in the correct position, some people get spinal headache, so they get a severe headache and need medication to treat the headache. So otherwise, epidural is deemed very, very safe these days.
Okay. Yeah. That's great. Then moving on to the next big fear, episiotomy and tearing. So these are common fears. What's the difference between the types of tears, like a small tear, a third, fourth degree tear, and episiotomy?
Actually, episiotomy is a cut that the doctor does to widen the area for the baby to come out. This is the vagina, this is the anus. In between, the space is called perineum. Unfortunately, in Asian, the perineal area is very short. In Caucasian and Westerners, it's wider. So having a short perineum, that means a tear into the anal canal or anal sphincter or anus is higher. The risk is higher. So generally, especially for my own practice, is I will always do an episiotomy for Asian patient, especially for the first time mummy. I put the cut away from the anus. So if it tears, it usually tears away from the anal canal and won't damage the anus. Once the anal canal or sphincter has been damaged, sometimes you get fecal incontinence in future. So by cutting away, not midline but away from the anus, sometimes you're trying to guide the tear away from the anus. People have done perineal stretch. That means you use a finger to stretch your tissues. This will help the tissues not to be so tight, but it does not help you to see whether you succeed in normal delivery because the bones will not change.
Right.
Yeah. So sometimes by stretching, it becomes not so tight, then it won't tear so badly. The problem with letting a person tear on its own without episiotomy, especially in Asian women, is there's a risk that it tear straight away all the way to the anus. And repair will not be easy. Sometimes you need to have subspecialists like urogynecologists to repair the area in very bad tears. So generally, we would prefer, if they were to tear away from the anus. Generally, we would prefer that we make a small cut so that you can direct the tear away from anus rather than guard it and let it tear naturally. And many times, if you tear naturally, you tear directly into the anus.
Okay, so how about someone who has the second delivery or third delivery? Because the first one I had episiotomy, but with my second and third, I had natural tears. So is there any guideline as to which one has better recovery?
Generally, if a doctor can guard the area and there's no tear, that's ideal. Not even tear. But your second baby was 4 kilograms. I'm sure the tear would have been bad.
Second degree.
Yeah, so if I had my way, when you have a big baby, I would definitely cut away so that there's better space and less risk of tear into the anus. So sometimes it depends on the size of the baby. Of course, you have delivered 4 or 5 babies, the area becomes more lax. Maybe it's easier for the baby to come out without tearing. Yes. But first, second one can be very tricky. First one definitely. Second one, I've done deliveries without episiotomy and without tests before, but I select my patient.
So it's really case to case when you assess during
depending on the baby size and the patient,
Right.
how big the patient, how small the patient is.
Right. Okay. So once the baby arrives, many moms start worrying about recovery and long-term changes to their body. What kind of bleeding is normal and when should moms seek help?
Well, generally in the first 6 to 8 weeks post-delivery, you will have some bleeding we call lochia, Lochia. It should not be fresh bleeding and it should not be a lot. In the first week, maybe more. You can some clots coming out sometimes, stay in your penny, but after the first week, it should be less, and less, especially when you are breastfeeding. Breastfeeding causes the hormone called oxytocin to be secreted, and this causes the womb to contract even more. That's why there's a term called after pain. After breastfeeding, you get contraction and pain. This contraction will help more of the blood to be excreted out, to be pushed out. Similarly, some people do massage of the womb, just as a postnatal massage of the womb. This will help the womb to contract faster and more blood to come out faster. But generally, there shouldn't be fresh bleeding. It should be bleeding mixed with discharges like what we call lochia that is not fresh. So sometimes it's the darker colored and sometimes clots.
Right, okay. So another worry we have is if I have a big baby, I'll end up with incontinence. So is that true?
As mentioned earlier about the percentage of incontinence, one of the main reasons for urinary incontinence and prolapse of the womb is childbirth. We know how big the vagina is, how big the baby's head. Once the baby head comes out, it can damage the tissues around. If the tissues around did not heal well, either you work so hard after delivery and not rest, or when there are bad tears, or when you have infection to the wound, or when the surgeon does not stitch the area in very well, then prolapse incontinence can occur. And unfortunately, many people do not do pelvic floor exercise when they're pregnant. So the womb is small, then it gets bigger and bigger. Tissues become stretch. If it overstretches, then the womb can prolapse and leakage of urine can occur. By doing pelvic floor exercise, the muscles will become elastic, so it prevents prolapse and incontinence. So it's important to do pelvic floor exercise once you're pregnant and forever after your delivery, forever.
How often do?
In the old days, we tell the patient do sets of 10. 10 morning, 10 afternoon, 10 nights. Of these 10, 2 sets will be short acting, squeeze for 1 second, long acting, squeeze for 10 seconds, and then same thing for afternoon and night. If I tell the patients this, they won't do it. Compliance is difficult. So these days, in generally, we'll tell the patient, squeeze your anus as often as you can. It can be while you're watching TV, while you're watching this program, while you're talking to me, when you're driving, all the time. Bodybuilders have such good muscles because they do it regularly. You cannot do pelvic floor exercise for 1 2 days, stop for 1 month, and then it will still be good. No, you have to do it regularly every day, as often as you can.
When should a woman seek help for incontinence or pelvic floor issues?
In simple terms, let's talk about urinary incontinence, for which is my subspecialty. So any leakage of urine, when you cough, sneeze, run and jump, is called stress urinary incontinence. It's different from when you are so urgent you cannot hold your urine and urine leak out. Because urgency and leakage, the treatment is with medication. But stress urinary incontinence, if you do pelvic floor exercise very well for 3 months and you still leak, generally urogynecologists will offer you surgery. This surgery these days, very, very fortunately, is very simple. 10-minute surgery can cure more than 90% of patients. That means out of 100 patients, more than 90 of them will not leak urine after this surgery. Simple, painless, and long-lasting. I'm one of the first few to do this surgery using the sling in Asia, and did my first case in 1998. And now we have 20-something years history. And that batch of people of more than 20 years, up to about 90% of them are still continent.
Right.
So these days, treatment is very simple. The most important thing, of course, is treatment is a last resort. Or treatment with surgery. Surgery is always a last resort. Urinary incontinence can be mild, moderate, severe. Mild, do pelvic floor exercise. Up to 50% will not require surgery. Moderate to severe usually require surgery. So if you have, for example, what we call jet urinary incontinence, you cough, your urine shoots out. Very unlikely you can escape surgery if you want to be continent. The next thing is prolapse, the womb dropping. 50% of people with urinary incontinence, stress urinary incontinence, have got pelvic organ prolapse. Pelvic organ prolapse can be of the bladder, the womb, or the intestine. 50% of people with pelvic organ prolapse will have urinary incontinence. They are linked. So, because it's the same set of muscles causing this problem. So, earlier I mentioned mild stress urinary incontinence, we do pelvic floor exercise. But if you have mild stress urinary incontinence and you also have prolapse, added two together, usually a doctor can offer you surgery. Prolapse can have different degree as well. This is the vagina. Inside the vagina is called grade 1. At the door of the vagina, grade 2. A little bit outside, grade 3. And when the whole womb drop out, is grade 4. Nobody should reach grade 4 before seeing a doctor. So at 2, maybe something needs to be done before you progress to the severe grade. Once you reach the severe grade, surgery has got poor results. Up to 30% after surgery will recur again unless you do special surgeries like some urogynecologists. We hook up or we put a net in to reduce recurrence. So the moral of the story is, once you have this problem, seek treatment early, and if a conservative treatment does not work, then we will resort to surgery. The earlier you do surgery, the better the success rate. The least the degree of the incontinence or prolapse, the better the success rate.
So in general, I guess, is there a time frame, like maybe 3 to 6 months, and it doesn't improve, we should just...
Generally, as mentioned earlier, we give the patients good physiotherapy for 3 months. Must be good physiotherapy. And if that fails, we can offer them surgery as an option.
Right. Do you have a quick checklist for postpartum recovery?
Well, generally, there are a few things that are important postpartum. Why there's such a thing called confinement period? That's because it costs you to be confined, for example, at home so that you don't run about and do many chores. Because the area, whether it's a C-section wound or your pelvic floor wound, must heal. So that part is good. But certain confinement kind of practice, I do not agree. For example, there are some people who said, I will not take a shower, I will not wash my hair. But if you are not clean, how do you look after a vulnerable baby? That I do not agree. And of course, there must be enough help. Other than enough help, there must be enough rest. Because the mummy, especially one doing breastfeeding all the time, especially demand breastfeeding to the breast, can be very, very tired. And when you're very, very tired and the baby may keep crying all the time and you cannot stop the baby from crying, very often it can drive a person into postnatal blues. Do not reach that stage. Always ventilate, share with your husband, your family members, ask for help, get people to help you. So there must be enough rest. Because if you are very tired out, you also will lose some drive and some determination to look after your baby, get depressed. So have enough rest, good nutrition, enough help, especially emotionally. Do not overexert. Those are important. Of course, the other thing is, do not forget, as a breastfeeding mom, you dehydrate faster, drink more fluid. Do not forget to continue to take your supplements. After delivery, whether you are having a C-section, or you had a C-section or you had normal delivery, you will lose blood for sure. So you need to build up that blood that you lost. So you have to continue to take your iron supplements, your folic acid for at least 3 months. Calcium and fish oil must be taken too. Fish oil is brain food for baby, will go to breast milk. Calcium is because you do not have menses, you're breastfeeding, you are like menopause, you need about 5 to 700 units of calcium for your own bone and for the baby as well. So continue supplements.
Right, okay. For moms listening who are pregnant and anxious about delivery, whether it's C-section, natural or induction, what is one piece of advice you'll give them to feel more confident?
Your child is worth every suffering you go through. Full stop. I think, we cannot predict, but most important, you must be mentally prepared. You must be well educated on this. It's useful to attend antenatal class because some things the doctors cannot teach you, like breastfeeding, how to look after the baby. So you have enough knowledge. You have to, for example, listen to Angeline and what she says and all the interviews. All these things are important as a knowledge, and be mentally prepared that it can end up in a C-section or normal delivery. Whatever way, do not suffer pain. Try to have good pain relief, and then make sure you have enough help. Your child is worth everything. So the journey is something that you will really love remembering. Do not remember it as hell and suffering. And the other thing that's very important, you may have a shitty day at work. When you get home, your spouse may not be able to cheer you up, but your kids can. So it's worth every bit you put in for your kid.
If you could give moms 3 key things to focus on for smoother postpartum recovery, what would they be?
First of all, you must have enough rest. Don't be tired, otherwise you'll be quite depressed sometimes. There must be enough nutrition. And the last thing is, there must be enough help, especially from husband, from other people, and especially emotionally. You have all these 3, you'll enjoy your postpartum period.
Okay. Thank you so much, Dr. Chong, for sharing your insights and helping us break down so many of the myths around childbirth. To all the mamas listening, remember every birth is unique, and being informed is one of the best ways to feel empowered. If you found today's episode helpful, share it with another mama who might need this reassurance, and follow a Mama's Diary for more conversations with experts who truly understand what we go through. Thank you.